Okay, so let's continue our discussion on the renal manifestation of indolent polycystic kidney disease. So far, we discussed stones and cyst hemorrhages, infections. Now, coming towards the most common complication or manifestation of this adult polycystic kidney disease, which is hypertension, and which should alarm a nephrologist that it should be treated in time, because it does not only decrease the progression of the disease itself, but it can prevent some other complications as well. So it can present clinically with microalbuminuria, proteinuria, hematuria. These are the risk factors, and hypertension itself can also increase the mortality and morbidity of the patient, because it itself is the cyst itself is associated with intracranial aneurysm, and if hypertension is there, so it will further butter up the condition. End-stage kidney disease, it occurs in 4 to 6 decades of life, and the average decline of GFR is this is important. The average decline of GFR is 4.4 to 5.9 if the patient is having the ADPKD. Usually, we know that beyond the age of 40 years, there is a 1 ml per minute decline per year decline in the GFR. That's normal with aging, your kidney age as well. But if there is a pathogenic condition in the form of this, so there is a quite accelerated rate of decline of the GFR. And men tends to progress to renal failure more rapidly than females at a very younger age. There are some risk factors for that as well. Other risk factors which can lead to early renal failure. There's the black race, diagnosis of ADPKD before 30 years, first episode of hematuria before 30, onset of hypertension, early onset of hypertension, you can say, before the age of 35, dyslipidemias or hyperlipidemias, and of course, if there is a sickle cell trait and if there is a truncating mutation. We'll come to these truncating mutations and other mutations that's been discussed in a scoring system, which is called ProPKD scoring. Coming to the HALT PKD trials, they were associated with the dietary sodium and its effect on the rate of the kidney growth in patients with ADPKD, and those who have GFR over 60, the rate of decline as compared to those, the rate of decline 20 to 60% males. The CRISP study, we discussed already that it's usually associated with the cyst volume, and it's a strong predictor of the renal decline. The more the cyst volume, the rapid decline in the renal function. So it's an independent predictor. Coming to the extrarenal manifestation. So extrarenal manifestation are usually the late manifestation, but it can present early as well if the disease is uncontrolled. By uncontrolled, I mean that the blood pressure is not controlled. There are hematuria episodes or cyst hemorrhage, repeated infections. So they can increase the possibility of early manifestation of extrarenal condition. On the top, you have polycystic liver disease. That's present in 80% of the patients and usually detected by the liver imaging. Intracranial aneurysms in 20 to 27% of the patient. This should be of prime importance in patients who have a positive family history, and those who have high-risk jobs. Like if there's a positive family history and with the jobs which are, needs to be taken into consideration, like if the patient is a scuba diver, or if the patient is a pilot, or if the patient is undergoing transplant. So they should be investigated thoroughly in that case. Mitral valve prolapse, retinoid cyst, and some other conditions like diverticulosis, bronchiectasis, congenital liver fibrosis, and fertility. Fertility usually a concern for males, because most of the patients, it's usually it's under the iceberg, tip of the iceberg, it's under the water, but it's usually there. So the cases has been reported where the ADPKD associated with infertility, so needs to be screened. So coming to the dreadful complication, which is intracranial aneurysm. It is present in 8% of the patient, and there is familial clustering as well. It occurs in 6% of the patient with a negative family history, and 16% of the patient, which is quite high, in positive family history. Mostly they are asymptomatic, but if they become symptomatic, there must be focal findings in the form of cranial paralysis, seizures, and some local compressions due to enlarging aneurysms. The annual rate of rupture of the cyst it depends upon the size of the cyst. If it's if it's smaller than 5 mm, so the chances are 0.5, less than 0.5. If it's greater than 10, so there are 4% chance. And mean age is 39 years. And most patients have normal renal functions, up to 29% of the patient with a normal BP at the time of rupture. So it means the cyst itself is likely to pop out and cause a dreadful complication. So who needs to be screened? Indication for, it's not indicated for all, provided if, like, I'll give you a scenario. If a patient has ADPKD with a positive family history, but he hasn't any episode, there's no episode. So you should go for screening of this patient? No, because there's a positive family history, but he hasn't any previous rupture or previous episodes. So this comes under the heading of indications. If the patient has a family history or subarachnoid hemorrhage, you should go for screening. Means ADPKD positive plus hemorrhage history positive, screen. Patient itself has a previous rupture, so you need to screen that. Patient undergoing any elective surgery for any potential hemodynamic instability, screen. High risk occupations needs to be screened, like airline pilots. So you have to screen them. The modality of choice is MRA, magnetic resonance angiography. It's diagnostic. CT can also give you the satisfactory result, but if contrasted contraindicated, go for MRA. A repeated screening of the patient with strong for family history, intracranial aneurysm, and rupture after 5 to 10 years is recommended. So you have to screen. So intracranial aneurysm can present as unruptured or ruptured. If unruptured, it can be asymptomatic or symptomatic. Asymptomatic is incidental. Symptomatic means in the form of cranial nerve compression, CNS compression, TIAs, headaches, and seizures. Rupture, if present, it comes with a dreadful clinical presentation in the form of thunderclap headache, subarachnoid hemorrhage, classical, neck stiffness, lower back pain, loss of consciousness, focal signs, or retinal hemorrhage. Rupture or symptomatic, what should you do? Like, how are you going to treat? So if it's rupture asymptomatic, go for surgical clipping. Asymptomatic, less than 5 millimeter of diameter, observe. How frequently you're going to observe? With MRA 6 monthly, then annually, and then less frequently if stabilized, so then you should just yearly observe it. If surgical intervention is indicated, if the cyst is large and it's unruptured but it's on the verge of rupturing, so then you have to go for surgical intervention. For a patient who was not fit for surgery, so then endovascular treatment with the platinum coils is indicated. These are the cysts in the circle of Willis. These are the cysts in the liver. Diagnostic modality, always ultrasound. These are criteria, ultrasound criteria for ADPKD. Among all the three, this is of importance. It's a unified criteria, revised unified criteria. If the patient age is 15 to 29, greater than 3 cysts, either unilateral or bilateral. That's ADPKD. 30 to 39, greater than 3, unilateral bilateral. 40 to 59, greater than 2 cysts in each kidney. And we 16, 4 cysts. So as discussed, diagnostic is imaging, genetics. Coming to the treatment. Treatment is based on the renal and extrarenal complications. Among renal, the topic we discussed, if there is pain, relieve it. Among relieving agents, we have narcotic analgesia for acute, given acutely, and short term because of the dependency. NSAIDs acute because it cannot be given prolonged and it can further deteriorate renal functions. TCAs, tricyclic antidepressants for chronic pains. Splanchnic nerve blockage is considered if all the three are not working. Most importantly, if Eugen size decompress the cyst, aspiration, or even we can go for use of a sclerosing agent in the form of ethanol and many others. If cyst hemorrhage, what are you going to do? Just conservatively, if it's observed for 7 days. Conservative treatment in the form of bed rest and analgesia. If it's huge and it's not controlled, the bleeding is uncontrolled, then we can think about arterial embolization. Cysts and urinary tract infection, the antibiotic of choice is trimethoprim, dexamethasone, and fluoroquinolone. That's because of the fact they have better cyst penetration and they are lipophilic agent which can penetrate the cyst easily and control the infection. For nephrolithiasis, for stone formation, adequate hydration, calcium citrate agents, ESWL, other modalities, and then flexible enteronephrooscopy indicated. Hypertension, how to control the hypertension. So ACE inhibitors and beta blockers. ACE inhibitors is the ideal choice, but we can add on the beta blockers and even calcium channel blocker for that matter. These are some landmark trials which were done in ADPKD. So far we have discussed this CRISP trial. Then there was TEMPO trial, HALT trial, HALT A and HALT B, and REPRISE. So these are some of the landmark trials which you need to remember. In CRISP we discussed that the kidney volume correlates with disease progression by annual MRIs. In HALT PKD, the discussion was on the goal of BP control if the early GFR greater than 60 and if the late GFR greater than this. And ACE inhibitors and ARBs were tried. TEMPO trial, tolvaptans which were compared with placebos they have some effect on the slowing the decline of the GFR, but it comes with the price of being more adverse effects. Similarly, the REPRISE was for late CKD. If you go beyond basics, so what's going on in the world for ADPKD? It's usually there are some classifications and some the prognostic value, and there are some novel therapies and the need for nephrectomy and what's in the pipeline. So we'll discuss one by one. My classification was basically for the prognostic value. It has 5 prognostic classes from lowest to highest. Class 1A, 1B, 1C, 1D, and 1E. So class C, D, E are at higher risk of progression, and the major advantage is to the ability to predict individual GFR at any point of time, and hence becoming or predicting the risk of ESRD. The ProPKD scoring system. This is just to predict that if the score is higher than 7 or 7, so there is a higher chance of going into ESRD. So the variables were male gender, age before, hypertension before 35, first geological event before 35. PKD mutation has got 2 points. This is also called truncating and non-truncating mutations. It has got non-truncating mutation has got 2 points, and truncating mutation has got 4 points. So if overall the score is high, so there is a high risk of progression. There is some grading system, or if the score is from 0 to 3, so that's intermediate, low risk. If it's from 4 to 6, it's intermediate risk. 7 and beyond, it comes in the red zone, and therefore high risk. Novel therapy, BP is our prime target to control blood pressure with ACE inhibitors or ARBs. Patient grade greater than 18 years to 50 years and GFR greater than 60. The target is to 110 by 75. The lower the BP, the better the control of the disease, or the better the delay risk of progression into ESRD. Increased fluid intake, more than 3 liters, while the GFR is behaving. Because if the GFR is not behaving and you're giving unjudiciously water, so the patient will go into volume overload. So this just to advantage. It can decrease the stone formation and partly by suppressing the plasma, vasopressin growth, vasopressin levels that can inhibit the cyst growth, because it's one of the cyst encouraging or growth factor which can increase the growth of the cyst. So tolvaptans were some introduced, and they are vasopressin 2 antagonist. Their role is to decrease the cyst burden and preserve kidney functions, and not everybody should receive it. The patients who are likely to receive it, the GFR should be 25, and who are at risk of rapid progression. Age less than 55, GFR less than 60. Average kidney length by ultrasound, CT MRI 16.5. Patient is less than 50 years. ProPKD score greater than 6. So these are the patients who should receive. Contraindications: age less than 18, if there's active liver disease, and if there's hypernatremia because of instability to respond to thirst or hypovolemia. The pipeline therapies are lucitanib, which is an oral tyrosine kinase inhibitor, still in the phase 2 trials, and it's for those patients whose GFR is greater than 60 and TKV is 750 mils. Reduced rate of kidney growth, and but there's no effect on the annual GFR. therapies which are not used anymore. So these are the therapies, some studied analogs, mTOR trials has been going on, but it has a good role in shrinkage of the cyst, but comes with a huge side effect profile. Indications for nephrectomy and ADPKD are the following: recurrent infection, suspected malignancy, extension of the native kidney, positive kidney to the pelvic surgical site. If the patient is in due for renal transplant, so you have to remove it. Uncontrolled renal hemorrhage, where intra-chemoembolization, partial embolization is contraindicated. Hernia due to large kidney size. So these are some of the indications for removal of the kidney, native kidney. Ideally, renal transplantation is the ideal choice, and there is the rate of recurrence in this condition. If the transplanted kidney has no mutation, so there won't be any rate of recurrence. So that's all about ADPKD. So far, many things are going on in the as far as the treatment is concerned, and other modalities, the research has been going on. We are still deficient in this, but this is some of the contribution from my side to understand the topic. And this is a brief understanding for such an extensive topic. So I hope you like it. Please do subscribe to my channel. Thank you.